So thanks for joining me this morning, Gerard and Joe. And you are already well known, so we're going to do a very short introduction for you both. We'll start off with Joe. Can you just give everyone listening a bit of background about how you got to this point in men's health, please?
Thanks, James. Well, my physiotherapy career started in 1994 when I graduated, and then I spent the next 15 years or so basically working in the musculoskeletal field, and I've always been interested in yoga, so I've taught yoga for many years. And then in 2005, my brother, who's a urologist, rang me up one day and said, could I assist him with his radical prostatectomy patients who were experiencing for the first time laparoscopic removals of the prostate. So he was in Western Australia, part of the early cases doing things in the minimally invasive surgical way, and he wanted patients to have preoperative pelvic floor training. So we basically teamed up. I followed him around for a year, watching him do surgery, and then as time went by, he sent me lots and lots of cases that he felt didn't need a surgical fix, and that a lot of the musculoskeletal physiotherapy practices, especially in the pain side of it, was something that I found I could do quite a lot more with, and he was struggling. He often found that there wasn't actually a surgical need for patients or medicinal needs. So really just over the years of seeing lots of different patients with complex things, that actually physiotherapy had a fairly easy pathway towards helping. I felt a bit bound to push it a bit further, and then ended up doing a PhD, which I finished in 2019. And the focus of that was on both Peyronie's disease, that I'd noticed in the clinic was becoming an issue, and also the protocols for pelvic floor muscle training and dysfunction in guys who had prostate cancer, especially for surgical patients. And mostly these days I'm working in the clinic, but I'm dabbling a little bit in research as I can.
Okay, fantastic. Gerard, you're known a little bit more over here, so can you just make yours much shorter?
Hi there. First of all, a big thanks to James for the invitation for doing the podcast, and a big thanks to Joe for joining us from Australia. I'm based in Birmingham and in London, and I've got 2 pelvic health clinics, and my clinic in Birmingham sees lots of men, mainly with male pelvic pain, see a lot of younger hard flaccid patients, and then the clinic in London is purely male pelvic health, and there we see the same again, a huge volume of male pelvic pain. And I was quite fortunate several years ago to meet a wonderful woman, Dr. Ruth Jones, who Joe knows also. And I worked with Ruth in her clinic in Southampton, and she trained me up. And then I met Joe, and Joe and I have been fortunate to have taught together in Japan, in Cape Town, and in the States for the APTA. So I feel quite blessed to have met Joe.
You are, that's not just saying it because Joe's here. He always says that. He always speaks very highly of you.
It's always embarrassing.
You missed 2 bits because your websites are fantastic, and you've got great resources on both. You do lots of CPD, Gerard. And yours is greenseminars.physio.
Yeah, so it's greenseminars.physio. And to be honest, since I've opened the London clinic, I've kind of taken a bit of a step back from that to focus on the clinics. But yeah, we do run some events, and obviously we're really pleased to have Joe back, because before COVID, Joe travelled to the UK. She taught for us in Birmingham, and she taught for us in Dublin. So I think that was 2018, Joe. And obviously because of COVID, Joe couldn't travel from Australia. So she taught a brilliant online course for us last year. And this year on the Saturday, Sunday, 2nd, 3rd of July, she's doing kind of a more advanced course this time. So rather than an introductory course, she's doing an advanced course, and that will be from UK time 8 in the morning till 12 in the afternoon.
Yeah, it's an online course again.
It's an online, yeah.
It's going to be recorded, and it's the Saturday and Sunday.
We've broken up a bit.
Got a bit of a delay there, yeah. So it's Saturday, Sunday, the 2nd, 3rd, and it's brilliant to have Joe back. And this one is online, live online. But hopefully, post-COVID, she'll be back.
Just as you said that, and that's on Eventbrite, isn't it? I've seen that, and I'll put a link on that afterwards, so it'll be a part of the podcast. And while Joe is struggling with Wi-Fi, you just mentioned that there is an introductory course. So for someone like me who, you know, we've been doing it about a year or so, I still wouldn't say I'm an expert by any means. So where is this being pitched in terms of it as an advanced versus introductory course?
I think this course that Joe's delivering is probably based at 2 groups of clinicians. So it's aimed at clinicians who already, one group who already work in male pelvic health, but maybe who want to get more knowledge around the more complex patients, such as those with Peyronie's disease, hard flaccid, the post-prostatectomy patients that just aren't really recovering as they should do. So those more complex, challenging post-prostatectomy patients, and also the pelvic pain patients who maybe just aren't getting better. That's one group it's aimed at. The other group is aimed at is people like yourself, James, who do quite a lot of focused shockwave for in male pelvic health, particularly around erectile dysfunction, because Joe will talk about her work in focused shockwave also. So it's kind of aimed at both. It's aimed at people who already worked seeing those kind of pelvic health patients, but also the people who, like all the colleagues from Venn, who already do focused shockwave, but just want to learn more about that, or thinking, well, we've got a focused shockwave unit, or we're about to buy one, but what role does it have in these pelvic health patients?
Okay, I mean, on nice segue to now Joe's come back. But you started off, as far as I understood, Joe, is that right? You started off using just normal therapeutic ultrasound to try and affect, was it either Peyronie's or erectile dysfunction?
Yeah, so it was actually pure coincidence. I had a patient, a radical prostatectomy patient, that he developed Peyronie's disease about 1 year after his surgery. And I was finishing off PhD in pelvic floor papers, and I just said, look, this is Peyronie's disease. He thought his cancer had returned because he had this severe sort of curvature with a large painful lump in the midsection of his penis, and he thought his cancer had returned, so he was really distressed. And I reassured him that it was something called Peyronie's disease and that I would look into it. Again, having my brother as an advocate all the time, and I just sort of said, what can you do for this? And he said, look, we don't really like to treat it with surgery until it's stabilized. There's usually 2 stages to Peyronie's disease. It's acute and painful for a good 12 to 18 months. After that, it tends to stabilize into a chronic phase, and then we can do surgical repair. He said there's many other treatments, but most of them don't work. They're not that much better than placebo. So he said surgery is something I can provide, but I won't provide it until I'm absolutely sure the condition is, no longer in the acute phase. So then I've potentially thought, well, maybe there is a role for physiotherapy. Looking into research, I found there'd been some case studies that have stretched back to the 1980s of using therapeutic ultrasound for Peyronie's. And I just said to this guy, look, I don't know if it's going to help. We went and did a penile duplex Doppler ultrasound to measure the plaque and measure the angle to try and work out where he was at. And then I progressed with this ultrasound, fiddled around with parameters and intensities. And after a period of weeks, he noticed a significant change, a reduction in his curve. And after we'd done 10 sessions, we went and had a repeat Doppler scan and found there was complete resolution of that plaque. So the radiologist and sonographer that was doing the assessment basically said they hadn't seen it ever reverse. And I remember the words, they said, you're onto something, Joe. We're going to work with you and let's get a bit of a pilot. So I did all of that, got about 10 guys, and we had pretty much 70% of guys responding well, with 100% of them resolving pain within just a few sessions, and then the reduction in curvature. So that was all a bit kind of random. And then I presented some early findings at some of the WCPT presentations or World Physio conferences. And there was quite a lot of interest from the urologists I was working with here. And before I knew it, I had a random control trial set up. And the results were really positive. So that's something that I'm, very happy to share, because we had 70% of men improving clinically and all 100% resolving of their pain. There was about 40% reduction in curve with just this simple application that any physiotherapist in the whole world can provide. Then I did a presentation.
Was that just alone, or did they combine it with pumps or stretching exercises? Was it just alone?
Yeah, so when you do, as I learned, when you do a random control trial, you can only have one parameter that you're measuring to get, a true indicator of any scientific change. And the fact that there was biological change that could be recorded with the ultrasound reducing the plaque or totally dissolving them, we had, a significant scientific effect. So then as I progressed with treatment, we did add the other parameters in, and then we got faster recovery. So we could encourage guys to have some use of the vacuum pumps. There's one called the Soma Correct from iMedi in the UK, which I learned about. We also now encourage patients to have tadalafil or Cialis as a daily treatment at 5 milligrams to try and help promote local blood flow. But there was 30% of patients that didn't actually respond. And they were the ones that had this calcified change, and the plaques weren't going to be broken down by the ultrasound. So then I was invited to trial the Storz Shockwave, low intensity focus Shockwave, which was like the second generation, versus the radial Shockwave, which hadn't had very promising outcomes. So for Peyronie's disease, I was actually quite hesitant. I thought, well, I'm helping 70% of the guys anyway. This Shockwave was presented to me as being a fairly expensive modality to purchase myself, but it also was presented in a way that I could actually make a lot of money out of it as well. And I just felt like this is a fairly vulnerable population, and there wasn't really the evidence behind it. So I'll say that I had the good fortune of trialing it. Initially, I was only going to have it for 6 weeks, but then because of COVID, I had it on trial for 8 months, and I was pretty much trying it on anybody that was coming through my rooms because it has the musculoskeletal capacity as well. And similarly, I was getting results in 70% of the patients that had been unresponsive to the therapeutic ultrasound because they had the calcified presentations. So these are patients who, if they have surgery, potentially have to get these calcified plaques removed, which ends up causing them erectile dysfunction. And most patients who have Peyronie's disease don't have erectile dysfunction, but they can have a physical deformity that prevents them from having, comfortable sexual activity or sexual activity at all, because if they have a penis that is so contorted and acute angle beyond what's physically possible for penetration. So it gave me another treatment option for these patients. And once again, the trials are emerging, but the volumes of patients that you can see in clinic, I find that I learn probably more from them anyway, versus trying to do
you just to recap, you for the 30% non-responders, 70% of that group you then went on to get good results with. And by results, you mean curvature or curvature and
curvature reduction, pain reduction.
So do you now treat, you go back to your brother's opinion about treating them when they're stable. Do you now treat Peyronie's when in the acute stage as well to try and resolve pain?
Yeah. So my favorite patient to get, and it's all the education, is someone who's only noticed a penile curvature change for less than 3 months. And what I normally do is they're in the acute phase. So I provide them with 3 therapeutic ultrasound sessions just to reduce that local inflammation, because the Shockwave can be quite painful in the acute stage. So I don't like to trial it on them and then stabilize it. I can only do 3 of those ultrasound sessions within 1 week. And then I'll find I can do 3 Shockwave sessions on the parameters recommended of about 3,000 shocks. And usually that settles down in an early acute phase. Depends on when the patients actually arrive at my door though. So they could be 10 years down the track still not have calcified plaque, but they have a more dense plaque. And I'll move straight to Shockwave. It depends a lot on their presentation.
Jo, what other, you mentioned that you trialed it on loads of patients during COVID.
Yeah.
And what other patients are you finding the Focus Shockwave useful with?
Okay, so I tried it on patients with chronic pelvic pain syndrome. So my very first patient I tried it with, I'd been doing a lot of internal therapy with him, and I looked after him for about 5 years. And he said, I'll happily be a binny gib, but he needed to come and see me once a week for this internal therapies, as well as a whole lot of spinal work and daily yoga-based stretching program. He had one treatment of the Shockwave and didn't need another treatment for 6 weeks. So he had a complete resolution of his pain for 6 weeks. And I was really shocked by that. So I was applying it to the perineum, as well as the external, or focusing on the external pelvic floor areas that had been like his active trigger points mostly. So I've never done internal therapy with Gim, and I see him run once every 3 or 4 months now, just for a one-off case. So he was my first chronic pelvic pain patient. And then I've had patients with hard flaccid syndrome that have responded really well. They do well when I combine the down training of the pelvic floor approaches and a whole load of breathing techniques and yoga-based principles. Sometimes a little bit of musculoskeletal spinal work. A lot of that's based on Peter Dornan's approach to pudendal neuralgia. And I've used it with patients with dysfunctional orgasm syndromes. Sometimes after radical prostatectomy, for example, men don't have any orgasm function. We don't expect them to have an ejaculate, but they can have a diminished orgasm, and that can be quite dissatisfying. Or they might have some climacturia, where there's a leakage of urine at the same time as climax, and I found we can apply the Shockwave to those patients as well.
Would that still be into the pelvic floor region?
Yeah, I've actually now, I fiddle around all the time. I've actually been applying it to the penile dorsal nerve, so along the penile dorsal shaft. So standard treatment is 3,000 shocks. And so I basically break it up into 6 different areas. So I use pelvic floor bilaterally for about 500 shocks, so 1,000 into the perineum. And then I found doing the penile shaft, 500 on the left, 500 on the right, the long dorsal nerve discentrally. And then I like to use a spot that I call the pudenda, which is at the crura, the base of the penis. And usually we can get a little bit more pudendal nerve activation by going to that area. And in the very first patient that I ever used it for post-prostatectomy erectile dysfunction, within 250 shocks to that pudenda area, there was an immediate erection, and that shocked both him and I, because he hadn't had an erection for 3.5 years. So then what happened was he noticed that he was getting spontaneous erections all week, and he came back the following week and he said, I can't believe what's happened, but it's like you've just rebooted everything. And so this time I said, do you mind if I video this to see if this happens again? I won't put your upper body in your facial features into it. And yeah, sure enough, we got that on film. So that then made me curious as to whether or not we could add this into patients earlier after prostatectomies. But then I was concerned about the oncological outcome. So I waited till anyone was 3 months post prostatectomy till they'd had their PSA clearance, but I wasn't able to reproduce those sort of results early on. So the neuropraxic effect, I think, takes a good 6 to 12 months to reach its maximum to enable the Shockwave, the Focus Shockwave, to basically spark things up that little bit further. So this is now a 2.5-year process of just ongoing development within my clinic, and I know there's some trials going on, and I'm curious to see what those trials reproduce.
Yeah.
And Joe, from your experience, because obviously you see a high volume of post-prostatectomy patients, do you feel that from using the shockwave that you're getting earlier return of erectile function in those men, or is it still too early?
You have to pick your patient. It's really helpful if they know that they've had nerve sparing, and if they've had bilateral nerve sparing, that's obviously better than unilateral nerve sparing. You would want to have a patient that had good erectile function before they had the surgery, and you'd probably want to wait at least 6 months post prostatectomy to ensure that they've had 2 PSA blood tests, just to ensure that the prostate cancer is well and truly not present in the area. So I feel that it's not something to rush into. And ironically, I will also mention that of those patients that I've seen who've actually reported improvement in erectile function, they've often coincidingly reported improved incontinence. So if they had a little bit of stress urinary incontinence that was still lingering, that seems to resolve quite quickly as well. An unexpected finding, but I've repeated that half a dozen times now too.
And I think here, apologies, James, I think here in the UK, there's, in the last probably about 2 years or so, there's more clinics are using focused shockwave. And James has been, very influential in training people how to do that. But is this a growth area in Australian physiotherapy? Are many kind of pelvic health physios using focused shockwave for male pelvic floor dysfunction, or is it very early days?
It's a very early days. I've actually encouraged a couple of other physiotherapists on the East Coast to purchase a machine. If they see a high number of patients, it's really worthwhile their investment, but it is a $40,000 machine. So, it's not something I've ever committed myself to purchasing anything like that in the past before. I think my ultrasound machines have only ever been real time, $7,000 or $8,000. So, it's quite an investment. I had the opportunity to trial it for 8 months. Otherwise, I wouldn't have probably looked into it. But yeah, I've got about 3 physiotherapists on Eastern Board of Australia that I regularly communicate with and encourage them along, and a few urologists as well. But it's a big commitment, and you do need to see a high number of male patients, I would think, to warrant that investment.
I think on that note, you touched upon something that is I always get slightly passionate about, because we're always at a certain age where ultrasound was the thing to do if you didn't have anything else to do, and you just slapped a bit of ultrasound on. Excuse me a second. A bit of ultrasound on, because what else are you going to do? And it doesn't do any harm. And shockwave has, particularly with focus, with the investment, I'm always advocating for like patient selection. And I think with this group, which you also touched upon earlier, you've got a really vulnerable set of patients that have been through some really traumatic times. And if you spent 40,000 quid or 30,000, whatever it is, in whatever country, there's a sense that the higher, because there is, with the treatment over here for erectile dysfunction, men's health stuff, there's a premium that we charge for that. And at the moment, I think that what you could bring, if I had a wish list for you to add in on the July course, would be to really hone in on patient selection. Say, look, these are the patients you should be seeing at this particular time, not just you spent this much money on a machine, and whoever comes through the door that's got some issue, you treat them 6 times and hope for the best. Because I still struggle with that patient selection with my physio that I work with, and it's like, are we going to take on that Peyronie's patient? They're still in a bit of pain. It's a large curvature, and it's going to be £1,200.
Yeah,
that's different to treating someone a few times of physio for 50 quid a go, and it hasn't worked out. You go, look, sorry, we gave it a go. You knew what you were in for. But that patient selection stuff, I'd really look forward to that, because I'd be scribing away, going, right, what sort of group are we going to be looking for, getting 70% success in or not? That would be great.
Yeah, sure. I think that's what I've learned. And as I said earlier, I wouldn't have purchased the machine if I didn't have the opportunity to trial it for 8 months without paying for it. And I was just charging patients like a minimal amount, 95. I said, I don't know if this is going to work. So, you know, if you're willing to give it a go, and I'm willing to go. And that gave me the, I guess, the trust to make that purchase.
Yeah.
But it was a rare opportunity.
So just on touching on the 2nd, 3rd of July, what are the other topics you'll be talking about? I think you're going to, one of the ones I've been on one of Gerard's courses, I'm still sketchy, I have to say, on hard flaccid syndrome and how that might be influenced by focused shockwave and so on and so forth. But what are the other topics you're going to be discussing on that weekend?
So we're going to be having quite a lot of discussion around what I clinically see, because a lot of the problem is we can't have evidence for everything that we do. And so that's one of the frustrations of doing research as well. Like, as you said earlier, do we offer multimodal treatment? Well, in clinical life we can, but in research life we can't. And I actually found it really difficult to hold back treatment because it hadn't been, you know, evidence-based knowledge yet when I was doing my ultrasound. So I wanted to let guys use a vacuum pump. I wanted to let guys know about the Cialis medication, and I couldn't. So it's really quite an ethical thing when you can't share all the knowledge that you have to help promote the well-being of the patient totally. So this course is actually about what it's really like in the clinic in everyday scenarios, and male pelvic pain is something that Gerard was quite keen for me to address. Normally, when Gerard and I teach together, he covers pelvic pain and I cover the prostate cancer stuff, but he's you know, invited me to share what I see, because sometimes, again, I'm lucky that I've got a really good rapport with a lot of the local urologists, so they'll send me cases. My biggest referral group is from urologists, whereas a lot of other areas it's sort of like internet guys trawling themselves and things like that. But I get lots of crazy patients that I find quite easy to sort out, and urologists are still scratching their heads about what I'm kind of going on about. But they say,
and I think, James, what Jo and I were really keen for her to do, because we put tons of planning into this, is that she, a bit like Jo said, that she would really kind of bring to the course what she does in the clinic, particularly with those patients who aren't responding as you should. They're all complex. All of these patients are complex, but it's really for the ones who maybe, they're not getting better, or there's a bit of a barrier to recovery. So it was really to bring what Jo does in the clinic to all of us so that we can all learn. Because I think Jo is very unique in that she sees, she sees a high volume of a real spectrum of complex male pelvic health, which in itself is quite unique.
Yeah. Okay. So I'm going to expect that, obviously my knowledge on things like hard flaccid and so forth and CPPS and will improve, but also I think from my perspective, the real world in clinic stuff, because if you talk to me as an osteopath about low back pain over the last 20 odd years, I've seen everything pretty much, and without even knowing it subconsciously, I'm going to decide what I'm going to do with that patient, but because we've been at this maybe 2 years as well, 2.5 years between my physio and I, and we've probably only still seen about 50 patients, and that for this complex thing is not many. So I mean, things like this where you can sort of collaborate between you two who have seen more than the rest of us put together, that's really exciting. It's going to be great.
Well, since 2005, that's 17 years now, I've pretty much dedicated myself to men's health. And in that time, I've seen more than 4,000 radical prostatectomy patients. And those numbers, are just now 50%, the other 50% of patients that I see, because it was all born from the prostate cancer, are erectile dysfunction, Peyronie's disease, chronic pelvic pain. And, I see 15 to 20 guys most days. So, it's a large number of people, and you just see these repeat trends. So I know it's in different countries like the US, it's really hard to get to see you have to wait months and months and months to be directed through their health system. And the NHS similarly, but here in Australia, we have a much easier pathway to.
And I think what's also quite inspiring about some of these kind of courses is that a lot of people who work in men's health will work on their own. They will have no peer group. They won't work with any other clinician. So it's quite powerful and inspiring to suddenly be in a group where you've got 20 or 30 other people who see the same patients as those people. Because I think sometimes people feel that they don't have that local peer support. So it's quite inspiring then to have people like Joe, lots of other people who work in men's health just in that kind of room together, like.
Yeah. And
it
indeed,
inspires
actually,
people to do more,
now
reach out
you're
to
in
help
London.
more men.
Now you're in London, Gerard. You know, I sent you that patient this week because, you know, I could have been one of those, which is my point, is I could have been one of those that bought the machine and then thought, goodness me, I'm in a lot of debt here. And then this patient came to see me this week, Joe. I don't know sure about GP. I won't go into too many details, but it was extremely complex. I mean, he had, he had
a real spectrum of stuff going on.
I mean, a real huge spectrum. And I had not heard of most of this stuff. And what was I going to do? Well, the nice thing now is, of course, because the community, Gerard, you know, it's only an hour and a half up the road. Can you see this chap and make sure that he's hopefully a reasonable candidate for some treatment or for some shockwave? Because otherwise I'd have been blindly doing this without, you know, and creating false hope. That's the worst thing, isn't it? You know, that would be not good.
Oh, it is.
Yeah. So look, I think that's pretty much everything I think we were planning on covering. Was there anything else that you think we need to cover other than just, I'll put those links on the podcast at the end so people know where to go on Eventbrite and to go to both of your websites for other courses you run, particularly your stuff with yoga and the pros stuff that you do, Joe, for exercises for post-prostatectomy. Is there anything else you want to add in, Gerard?
No, just a big thank you for having this conversation. I know that my work in men's health only came about through a conversation with my brother, but all around the world, I'm always shocked at how many physios aren't working in men's health when it's 50% of the population, is born with male anatomy. So we've got lots and lots to fill in and learn. I'm no expert. I've just had, the fortune of working with
that's the humblest thing you said.
Can I just say one thing finally, and I think Joe will be interested in this. When Joe and I have taught together, we've worked really, really, really hard to encourage males to attend the courses. And that's been quite hard work, but it's been very rewarding. So we've whenever we've taught anywhere, we've made a big effort to get guys to come as well to the courses. However, Joe, when you go to any of the Shockwave events, it's predominantly males.
Oh, men love toys. Men love toys, shiny toys.
But also, it's not predominantly physiotherapists. It's predominantly osteopaths like James. So so there is a real need to still reach out to that physiotherapy community.